Assalamu alaikum wa rahmatullah. Peace be upon you all. So essentially, my goal is to make this presentation as interactive as possible. I know there is limitation because now it's a WebEx, but I will endeavor to do that as much as I can. So how about that?
Yes, super. Excellent.
So basically, the objectives of the talk is to discuss, the management of pediatric renal tumors and covering the logical steps of managing them, the logical practical steps starting from evaluation, perioperative management, principles of surgery and postoperative care. And we can touch also on some new protocols in recent papers. I'll start with posting this question. The following statements regarding Wilms tumor are correct, except A, lymph node sampling is essential for staging. B, intravascular extension is associated with poor oncologic outcome. C, metastatic disease is favorable biology, have good survival. D, en bloc resection of other organs is not required. So you can post your answers in the chat and we will revisit the answer maybe at the end of the presentation. Starting with the evaluation, the first question to be asked is, what is the classical presentation of a child with Wilms tumor? Yes, I agree. It's essentially a painless mass. The peak incidence of Wilms tumor which is basically 90% of renal tumor. That's why it will be the core and the focus of this talk, is between 2 and 4 years. The incidence of other tumors, especially renal cell carcinoma, start to increase beyond the age of 10 years, as the graph here shows. As I mentioned, most children with Wilms tumor present with asymptomatic mass. They are generally well-looking, and the mass is discovered incidentally by parents and caregiver. This is in contrast to neuroblastoma, which most of the time they present with being ill-looking, secondary to the catecholamine surge in their blood, the metastatic burden that most of children with neuroblastoma present with. In the other hand, Wilms tumor patient looks really well. It's just an incidental mass that can be. Obviously, there is some smaller percentage of patients who can present with pain, with high blood pressure, due to the activation of angiotensin cascade. 7% of all childhood cancer is Wilms tumor. And basically, as I mentioned earlier on, it's more than 90% of renal tumors. In actually some part of the world, it's the commonest solid tumor. In the Western United States and Europe, the most common solid tumor is neuroblastoma, followed by Wilms tumor. But in some other part of the world, actually, Wilms tumor constitute the commonest. Incidence is 8 cases per 1 million. That translate to about 650 cases per year in the United States. 10% of the patients with Wilms tumor reported to have congenital anomalies, either related to WT1, Quagga, or Dennis-Dash syndrome, or related to mutation in WT2, like Nichols-Wiedemann syndrome, Erlen and leaf remaining. So it's essential part of the evaluation to look for stigmata of associated congenital anomalies like macroglossia in Becker's-Wiedemann syndrome, and also looking at some subtle changes in terms of hemihypertrophy. As you can see in the image, one limb of this child is larger than the other. Also, in the evaluation, a history of bleeding tendency is important, since one of the paraneoplastic phenomena that can occur with Wilms tumor is von Willebrand disease picture, and that obviously has implication at the time of inserting a line. It could cause bleeding, or at the time of the tumor resection. So screening for bleeding tendency is also a component of the initial evaluation. In terms of prognostication and knowing which patient does better than the other, prognostic factors are histopathology, stage, molecular feature. 1Q gain is the most powerful of these, but LOH of 1P or 16Q, or LOH of 11P, 15 are also one of those marks that are reflective of the tumor biology and age. Anaplastic and sarcomatous variants constitute only about 10% of Wilms tumor. And as we said, the favorable biology is the most common histology of Wilms tumor. However, this tiny percentage of unfavorable biology accounts for more than 50% of mortality. That really reflects on the power of histology on determining Wilms tumor. As you can see, this is the nice triphasic picture on the your left side, with showing basically the plastema in a pink stroma and a nice tubular structure that has been formed. We see this picture more in the part of the world where we practice upfront resection, while in the SIOP area, or area which gives more neoadjuvant chemotherapy, obviously that picture is changed since the high percentage of necrosis really occurs in favorable histology. On the other side here, this is an anaplastic Wilms tumor. As you can see in the center of the picture, how large some nuclei are and how variable the shape of the nuclei in the slides. Obviously, this is a very poor prognosis histology. And as we're going to see, we go forward, that histology in tumor biology is way stronger than stage. Talking about other renal tumors, clear cell sarcoma of the kidney, you can see that outcome is really good for early stages, stage 1, stage 2, and stage 3. However, stage 4 metastatic clear cell sarcoma has a really poor outcome. In the age of patient with clear cell sarcoma is more than 12 months. The patient with more than 12 months of age have better event-free survival and overall survival. And the most common site of relapse for clear cell sarcoma is brain. On the other hand, malignant rhabdoid tumors occurs in young infant with a median age of 11 months. 85% of those patients are less than 2 years. This tumor is also associated with a second primary of the midline in the brain and has a characteristic deletion of 22q11 to 12. The outcome of malignant rhabdoid tumor is dismal. This has not changed during progressive intensification of through the decades of chemotherapy, with 4-year survival for stage 1 and 2 is about 41%, and for stage 3, 4, and 5 is only around 16%. Also, survival is related to age in this tumor. In the younger the patient, actually, the worse the prognosis. For a patient who are less than 6 months, the overall survival is only around 9%. Moving to the workup that is required for Wilms tumor: complete blood count, complete metabolic panel, including renal function tests. Since this patient is going to have a nephrectomy, it's good to have a baseline kidney function test and liver function test, urinary analysis, and a coagulation screen to screen for von Willebrand disease that occurs in about 1 to 8%. I'm going to talk about the imaging of the primary in the next slide. But now I'll just devote this to the staging imaging, CT scan versus X-ray. CT scan is more sensitive to detect X-ray, and as 15% of patients will present with pulmonary metastasis. When meta-analyzing the study that comparing CT scan guided therapy versus X-ray guided therapy, would see that there is a significant improvement in the event-free survival when the therapy is guided by CT chest. However, not everything that is seen on a CT is tumor, and when the lesion is radiologically doesn't appear like a metastatic nodule, then a further workup to confirm that is required. There is some secondary evaluation for some specific histology. Clear cell sarcoma, what would be a secondary evaluation required for that tumor from what we have discussed early on? We talked about the most common site for relapse is brain, and bone as well. So bone scan and brain CT and MRI is required. For malignant rhabdoid tumor, this tumor can be associated with a second primary in the brain. So again, primary brain MRI for associated tumor is also required in this particular histology. In terms of imaging the primary side, abdominal cross-sectional imaging are superior to ultrasound, since it gives more details on the anatomy and the relationship of the vasculature to the tumor, and it really helps in the operative planning. And you can find in 10 to 15% of patients a thrombus that can be in the IVC or in the atrium in 4%, and only on the renal vein in 11% of patients. Also, in 5%, another tumor on the contralateral side can be found in the case of bilateral Wilms tumor. So the diagnosis of Wilms tumor can only be can really settle only by imaging. Biopsy is not really required. But when I say imaging, then you have to have a typical criteria, a typical picture, typical clinical picture, that the patient is older than 6 months, for the reason that we're going to discuss later, and younger than 10 years. That's a sort of a typical age. Doesn't have any atypical clinical presentation, septicemia or south inflammation. Hypercalcemia is also, although not very specific, but one of the atypical signs that can alert the possibility of malignant rhabdoid tumor. Also, when on the imaging, there's no visible normal parenchyma, because the Wilms tumor tend to push structure. It tends to push the normal parenchyma of the kidney and form what we call it the claw sign of a normal parenchyma of the kidney surrounding the tumor. Or if there is an extrarenal tumor, very large lymph nodes, intratumoral calcification, pulmonary metastasis in less than 2 years. This is obviously not typical of Wilms tumor, and it's also highlight the possibility of rhabdoid. Intratumoral calcification will raise the possibility of neuroblastoma. So these are all atypical pictures. So in the absence of atypical picture, cross-sectional imaging is all what's obviously in the typical age and typical clinical picture is all what is required for diagnosis and can justify starting neoadjuvant chemotherapy without obtaining biopsy. So I want you to look at the imaging on the right and on the left, and you can see, I use my laser pointer, that the tumor is here. There's a claw sign, the normal kidney parenchyma around the tumor. These are obviously typical picture of Wilms tumor. On this side, this left side tumor, you can also see the tumor. You can see the normal kidney being pushed also in a claw sort of appearance. Okay. Here on this picture, you can already see some intratumoral calcification. This is not really typical of Wilms tumor. And if you look at the other image, you start seeing encasement of vasculature where the renal artery is encased. The kidney is not really destroyed per se, but pushed. You can see the entire kidney is down there pushed, and you may also see some encasement of more major vasculature. This is all an alarm to tell the diagnosis is not Wilms tumor. This is likely to be a neuroblastoma. It's very important to know that preoperatively, since chemotherapy and approach is very different. Also, I'm going to show this next image, and you can then describe what you're seeing. Basically, the two kidneys here appear abnormal. However, you can see in the middle what appears to be like a normal kidney parenchyma. However, there's like a halo around the kidney, all around it, and this picture is typical of diffuse hyperplastic perilobar nephroplastomatosis. And this picture is enough also for the diagnosis of the nephroplastomatosis, and biopsy is not going to help, since in order to the only thing that differentiates the nephroplastomatosis from Wilms tumor is the capsule. Otherwise, histologically, they look the same. So a biopsy won't show a capsule, but again, it's not going to exclude the capsule unless the entire tumor is resected, which is not desirable, obviously. In this case, we need to avoid doing nephrectomy for nephroplastomatosis, since they are high risk of developing Wilms tumor and will require in the future nephron-sparing resection. So these patients are treated with chemotherapy only based on imaging. And here on this picture, although you can see, you won't be able to miss a massive tumor on the right side here. Wilms was a nice close sign, but you can see on the other side there's also a Wilms tumor, and that's occurs in 50% and should be sometimes the other side tumor is subtle and small, and attention should be paid to pick that, since also approach is different for bilateral Wilms tumor. So as I mentioned, biopsy is not really indicated for radiological Wilms tumor unless there is atypical radiological or clinical picture, or if the patient has typical picture and has been started on chemotherapy, and after 6 weeks of the 3-drug chemotherapy, there's less than 50% reduction. That raises the possibility of unfavorable biology that may not be responsive to tumor. It could be obviously anaplastic, or could be just some sort of a differentiation of the tumor to a rhabdoid differentiation that is not high risk, but obviously is not going to respond to chemotherapy, and surgery will be then the next step rather than extending the course of chemotherapy. And studies have showed that adopting that approach of starting chemotherapy based only on imaging and obviously typical clinical picture does not really result in giving inappropriate treatment in high percentages. Only in about 5%. Maybe some patients will get chemotherapy that are not appropriate for the histology, but actually in more recent study, this percentage is less than 1%. So it's quite safe to adopt the SIOP, the current SIOP obviously protocol, where there is no biopsy required for typical image and typical. Previously, the UK protocol used to mandate biopsy before starting chemotherapy, but I think that has changed now. So moving from the initial workup to the staging, which really in simple terms, stage 1, you can see the tumor is really contained within the kidney. In stage 2 is sort of reaching the capsule. Stage 3, it's beyond the capsule or in the lymph node, giving the possibility of some residual microscopic disease somewhere. And obviously stage 4, when it's metastatic and reaching other organs, most commonly the lung. And stage 5 is for bilateral Wilms tumor. That staging system is also therapy will be based on the staging system, but also will be based on the tumor biology and the risk of the histology. For the SIOP, to simplify also the risk-based stratification of the histology, obviously SIOP gives neoadjuvant chemotherapy first. So if you see that the tumor is completely necrotic, this is low risk tumor. Anything apart from completely necrotic will fall into the intermediate risk. These are all rhabdoid differentiation, focal aplasia, or plastema that is less than 66% dominant. The high risk is for diffuse anaplasia, for plastema that is more than 66% after chemotherapy, and for the other unfavorable histology like rhabdoid tumor and clear cell sarcoma of the kidney. And obviously there is a direct relationship between the stage and the prognosis. Generally, Wilms tumor has a really fantastic prognosis, an overall survivor in the 90s. And for stage 1, with favorable histology, the recurrence-free survival is 94, and overall survivor reaches 100. And if you go down, even in the metastatic stage 4, you still have a really good, reasonable overall survivor of 86%. And that's for a patient with isolated lung only is even better with overall survivor reaching 96%. In terms of staging, surgery has a really major role in staging of Wilms tumor, as we've seen in the staging system, that lymph node sampling is quite important on accurate risk stratification and staging of the tumor. And failure to biopsy, as I've seen shown in the picture of Schamberger paper, is associated with increased incidence of local relapse, and obviously survival after local relapse is poor. So all steps should be done to mitigate and try and prevent relapse as much as possible with adequate staging and adequate therapy. Lymph nodes involvement with tumor has been demonstrated to be the most significant stage 3 factor for relapse, because we know stage 3 can be because of a thrombus, because of a tumor extension beyond the capsule, or because of lymph node involvement. Lymph node involvement seem to be the most powerful stage 3 determinant linked to outcome, obviously. And only adequate biopsy of lymph nodes will accurately stage 1 tumor. Inspection by surgeon is notoriously poor. If you look and see, this is a large lymph node, this is a small lymph node, that doesn't really predict much tumors. Some large lymph node can be reactionary, and some small normal appearing lymph node can still harbor metastatic disease. So the only way is really to adequately biopsy lymph nodes. And Dr. Sajid Qureshi from Tata recently published this paper in an effort to standardize the lymph node sampling for Wilms tumor, showing those different stations where the tumor can be biopsied. Obviously, for the left side, those stations will be included, and for the right side, those stations are the relevant stations. And in this diagram, he shows how frequently was the positive lymph node was found. And you can see here on a overall, Hyler seemed to be obviously the most high yield lymph node. For right side tumor, obviously Hyler, but also aortocaval above the renal artery and below the renal artery. There was lymph node positive found there. Similarly on our left side, although Hyler was the highest, also in the below the renal artery aortocaval area, some positive lymph nodes were found. So these are really the boundaries of sampling, and obviously nobody should go at that level where the celiac and that's not really desired to sample, or below the inferior mesenteric artery, since that is also associated with morbidities, and in terms of the autonomic nervous system damage in that area, there was no known benefit. So that the template is really around that area. But then how many lymph nodes are enough? So this paper attempted to use the National Cancer Database and model to use modeling, mathematical modeling, to see when the chance of false negative is minimized. And that modeling gave us the number of, between 6 to 10 lymph nodes is what is needed probably to have a high yield. However, Ertan presented in the SIOP France how feasible is it to get more than 6 lymph nodes, and this is really challenging to surgically harvest these lymph nodes, especially in the post-neoadjuvant chemotherapy. But with collaboration between the surgeon and pathologist, this can be achieved, where this pathologist could look even on lymph node that submitted unblocked with the nephrectomy. Moving to the perioperative management of Wilms tumor. So obviously we know that there is 2 protocols posing multiple research questions. It's COG group and the SIOP. And the main difference between the 2 approaches is the utilization of neoadjuvant chemotherapy in the SIOP. And it's worth saying results from the COG and the SIOP are similar. Same survival, same outcome. So there's doesn't seem to be there is any clear advantage in terms of survival and event-free survival between SIOP and COG. An attempt to adapt the protocols to limited resource setting. This paper showed basically a simplified approach to what, as I can show here in the table, that low risk gets 2 drugs basically, and intermediate risk again gets 2 drugs, except if they're stage 3, then they get 3 drugs, and obviously they get also radiation locally. High risk all get 3 drugs. And comparing the contemporary SIOP umbrella protocol to the COG, as you can see down in the blue box, with the EE4A protocol was 2 drugs, DD4A a 3 drug, and some high risk protocols. But to really not to go into too much details and just summarize the similarity, that again you find themes that stage 1 and stage 2 generally receive 2 drugs without need for radiation therapy, with the exception obviously of high risk biology and high unfavorable histology. And for stage 3, generally 3 drugs with flank radiation is required. But I wanted to really touch on some historic perspective of the rationale for using PSYOP, and that can inform our decision of when to use neoadjuvant chemotherapy and when not to use it. PSYOP was initially using upfront resection, but they were faced with a really high percentage of tumor rupture. That's when, in this paper, this is a really old paper from the 70s, they utilized neoadjuvant radiation therapy, and that sort of neoadjuvant therapy decreased the rate of tumor rupture significantly. This holds true until today, I think, because this randomized control, the UK trial, this randomized control trial examined that same question with using neoadjuvant chemotherapy, and obviously found a significant reduction in incidence of tumor rupture. It makes tumor resection easier, which shrinking decreases the spillage and bleeding and complication to some extent. And it was found also to decrease the use of radiation therapy and doxorubicin by 20%. Then utilizing neoadjuvant chemotherapy to mitigate that risk is a reasonable approach. In terms of radiation therapy, obviously radiation therapy has a primary radiation therapy protocols and also what's called for the metastatic site. And really to summarize, if you have a stage 3, apart from low risk, then radiation therapy is required for the flank at least. But if the stage 3 was caused by a diffuse spillage of the tumor, then a whole abdomen radiation will be required. For the high-risk diffuse anaplasia, even for stage 2, radiation therapy is required. In terms of lung radiation for metastasis, without going into too much details in this PSYOP umbrella table in front of you, we can really divide the patient to either complete remission, or rapid responder, complete responder, or patient who don't achieve complete remission with the initial phase of neoadjuvant chemotherapy. If remission and the lung metastasis completely disappeared with neoadjuvant chemotherapy, then lung radiation is not really required. And if a small residual disease is left in the lung that is amenable to resection, and resection is feasible, is like, let's say, one nodule that is left is amenable to resection, is resected, and it was confirmed to be histologically dead tumor with no viable cells, then again radiation of the lung can be avoided. Otherwise, radiation will be indicated. Moving to the third modality, which is the modality of interest for us, we talked about chemotherapy, we talked about radiation therapy, surgery. What is really the philosophy and the goal of surgery? Is to ensure complete tumor removal without rupture, since rupture really changed the picture significantly. And also the goal of surgery is to assess the extent of the disease in terms of performing adequate lymph node sampling, in palpating for the renal vein and the IVC to ensure that there is no tumor extension, intravascular tumor extension that was missed by imaging. Those are all key principles of surgery. And a key principle is obviously adequate access. Struggling through an inadequate access and ending up with tumor rupture should be definitely discouraged. Adequate access is always required. Resection of continuous organ is hardly ever indicated. It's acceptable to resect a diaphragm. It's also obviously very acceptable to resect adjacent adrenal tumor en bloc, but to go and resect pancreas or other organs, that's not generally not required, except in very limited scenarios, since neoadjuvant chemotherapy most of the time shrink the tumor significantly, and the Wilms tumor generally pushes organ rather than invades organ. I'll go back to Schamberger paper about surgery-related factor and local recurrence of Wilms tumor in the National Wilms Tumor Study 4, and get some of the important highlights of that study, that tumor rupture increases significantly tumor recurrence, and tumor recurrence has a really poor outcome. So we should do all what we can to prevent rupture, not to end up in the scenario of tumor recurrence. And as I mentioned, I would like to highlight adequate access for large tumor is key. Where the question also, when it comes to surgery, where surgery should happen? Should surgery happen in peripheral hospitals or in high volume hospital, high volume surgeon? When we did the meta-analysis for our studies, we found no significant difference, maybe in overall survival and recurrence, but maybe it was favoring high volume center. By looking at tumor spillage, it was definitely significantly less in high volume centers, and the need for radiation therapy was consequently also less in these high volume centers. And that just really, put and this actually the case for most childhood cancers, since they are really rare. Solid tumor and pediatric are generally not. There is no high volume of these cases. They are generally better done in reference center with high volume, high experience. However, this recommendation should be also within the context. If there is adequate referral system that is in place, and there's no limitation of access to patients from everywhere in the country to this reference center. Otherwise, that recommendation cannot be made in a vacuum. I will touch on some COG new protocols, focusing on the ARNA 1821, which is pertaining to favorable histology Wilms tumor stage 1 to 4, including the also very low risk, standard and high risk. You can see here that the criteria for observation only, which I'm going to discuss in the next slide in more details, is going to expand. And there is also a modification in the chemotherapy regimen with substitution irinotecan instead of doxorubicin for stage 2 with adverse biology, and also utilizing some new regimen MVI plus IT. So really, to summarize what I just mentioned on the treating Wilms tumor with surgery only, in this study, RNE 0532, it was successfully demonstrated that stage 1 favorable histology. They are less than 2 years of age, with small tumors basically weighing less than 550 grams, with absence of adverse biological features, that is 1P and 16Q LOH, and absence of renal tumor predisposition syndrome. When these patients were treated with upfront resection and no chemotherapy, although their event-free survival was higher than the previous study when they were treated with chemotherapy, there were overall survival was 100%. So the patient who developed recurrence in this group were salvageable, and that sort of built the ground for the next new protocol, RNA 1821, where again the inclusion criteria for surgery only will be stage 1 favorable histology. Age is going to be expanded from less than 2 years to less than 4 years. The tumor weight is going to be expanded to any tumor weight. But again, it's very important to know the absence of adverse biological features, including 1Q gain, which we found that is more powerful, 1P and 16Q LOH, LOH 11P 15. Again, also absence of tumor predisposition syndrome. And those patients to be eligible to be treated in this protocol, lymph node sampling has to be done and known, so to accurately state them. The epithelial predominant tumor, all of them, there is no age limit, are going to be eligible for this protocol. So this is going to increase the number of patients eligible for this research question of treating Wilms tumor. These specific criteria: surgery only and no chemotherapy, upfront surgery only and no chemotherapy. It has to be said that the safe and appropriate identification of these very low-risk treatment group will require advanced molecular testing and diagnostic, which may not always be available in NMIC. So this is really has a limited applicability, this protocol. And still a research question. It's not standard of care, and we will only know when that study is done and concluded whether this approach is safe or not. So the lymph node sampling in this new protocol is aimed to decrease the failure rate of lymph node sampling from 14% to 7%. And to be able to do that, there will be some requirement for surgeons to be encouraged to submit at least 5 lymph nodes, and at least 1 lymph node will be required to be enrolled in the protocol, and a lymph node map for sampling will be provided for surgeon to aid that process. Obviously, that's within the study protocol. So now we'll go into a more interactive component of this discussion. I'm going to show this image and ask you, what can you see? I know you can see the tumor. Yes, you're right. You can see also a thrombus within the IVC. So this is a Wilms tumor with intravascular thrombus, as it can be seen more clearly here. You see the contrast in the IVC, but tumor is filling the upper part of the IVC and extending significantly upwards. So do those patients require neoadjuvant chemotherapy? I think I've answered this question already, because I posed the question of for how long. I think there's no question that they really need neoadjuvant chemotherapy to shrink the IVC thrombus down. But for how long is that neoadjuvant chemotherapy needed? Do we give them standard lengths of chemotherapy for 4 to 6 weeks, or expand the neoadjuvant chemotherapy beyond that to ensure that we get good, adequate shrinkage? Well, I agree with you. We should only stick to standard neoadjuvant chemotherapy and not to give them expanded course of neoadjuvant chemotherapy, as this study basically examined the literature on study on this matter and found that extending that there is no evidence that prolonged course of neoadjuvant chemotherapy beyond recommended protocol gives any additional benefits in treating intravascular extension of Wilms tumor. So, the standard 4 to 6 weeks should suffice. So then the second question, shall we do a cavectomy and remove the tumor from the IVC and then reconstruct the IVC, or should we do a cavectomy? Obviously, this is a complicated question, and the answer, of course, is it depends. And to just put more light on the literature that could inform this decision, that this is not specific to Wilms tumor, this paper, but it's multiple different tumors with intravascular extension that underwent cavectomy and resection of the thrombus and reconstruction of the IVC. And it was found that about 50% of these tumor IVCs remain patent. There's a significant percentage that thrombosed, and this paper, which was presented in this SIOP France, talking about cavectomy without reconstruction for Wilms tumor with inferior vena cava involved, and essentially, really the message home in the summary: if you have a completely obstructed IVC, obviously, if the IVC is chronically completely obstructed, the body has already formed collaterals, and is not relying on the IVC. There is significant, venous drainage, adequate venous drainage around the IVC in the retroperitoneum, or however the anatomy of the collateral draining the veins. So then there will be no point of really doing a cavectomy and reconstructing the IVC for multiple reasons. One of the important reason, that the thrombus will be stuck to the wall of the IVC, sometimes almost inseparable. The other reason, there's no traffic through that IVC, there's no flow. So even if we were successful to remove the tumor from a completely obstructed IVC with a well-established collateral, then it will thrombose back because the flow is going through the collateral. There's no significant flow through the IVC. So in scenarios where the IVC is completely occluded, and that can be verified with CT scan, with dual contrast, and can also be verified intraoperatively at the time of examining the IVC. In some scenario, one may start with a cavotomy and found that there's essentially there's no lumen for the IVC and it's completely occluded. When putting that together with a known preoperative image, that could justify then going ahead and removing the IVC en bloc as a cavotomy. So just in general, we can stage that this is obviously not tumor staging, but we're staging the thrombus, how bad the thrombus is. Stage 1 will be thrombus in the renal vein. Stage 2, that's obviously straightforward. They can just make sure at the time of resecting the Wilms tumor that the renal vein is palpated, and we know that we've gone beyond the thrombus and the renal vein, and then we can tie the renal vein flush with the IVC beyond the thrombus, and then that will facilitate resection of the tumor and thrombus en bloc. That should be technically straightforward. For stage 2, the tumor has gone into the IVC, but it's below the hepatic vein. Stage 3, the thrombus is at the level of the hepatic veins. And in stage 4, the thrombus is in the right atrium or beyond in the ventricle. The surgical strategy varies based on which stage we're dealing with. Obviously, I've already covered stage 1, which is straightforward most of the time to remove that. However, sometimes it may require applying as like a Satinsky clamp on the IVC to ensure that the thrombus is removed completely within the renal vein. Then the IVC can be repaired on the side. For stage 2, the control of the above the thrombus, below the thrombus, and controlling the contralateral renal vein is required prior to forming the cavotomy and then removing the thrombus en bloc with the tumor from the IVC. Stage 3 is really challenging, where the thrombus is at the level of the hepatic vein. Some literature and recommendation has suggested those patients should go straight for cardiac bypass. Obviously, I'm talking in the context that all these patients receive neoadjuvant chemotherapy to shrink the tumor as much as possible using the standard of care lengths of chemotherapy. But after that, after the chemotherapy, we're still faced with that sort of stage. Then this is the surgical study that should be adopted. When it's at the level of the hepatic vein, as I mentioned, some recommended going straight to IVC. However, some other authors were able to have bypass ready as standby, but utilize advanced hepatic maneuvers to isolate the hepatic veins and control them, since the tumor does not extend to the hepatic veins, but at that transitional area, and then controlling below the thrombus as well, and then be able to avoid the bypass by removing the thrombus this way. Obviously, for a tumor that is above the diaphragm, then bypass is mandatory. Cardiopulmonary bypass is no other way of removing the thrombus except doing that. And that's just a picture of this is a stage 2, which is below the hepatic vein, and we see the above and below, and then we see also is controlling the ipsilateral vein and the contralateral vein in this picture. And this is for stage 2, the time of forming the venotomy and teasing and removing thrombus from the lumen of the IVC. Obviously, this picture shows a patient who has stage 4, where it's extending above the diaphragm, and that's where cardiopulmonary bypass is required to open the atrium and retrieve the tumor thrombus. So another scenario that's worth discussing, this is a 6-month-old female presented as a palpable left-sided renal mass. Ultrasound and CT scan demonstrated a primary cystic lesion. What is this tumor? Yes, I agree, it's congenital mesodysplastic nephroma. So what should we do then for this? What is the appropriate next step? Obviously, these patients don't require biopsy or cannot be treated as observation or partial nephrectomy. It's just basically total radical nephrectomy is the treatment of choice. All right, so then what can you see here? I want to bring your attention to the shape of the contralateral tumor here. As you can see, a large tumor here with a close sign. If we go on the same image deeper a little bit, you see the contralateral kidney. What's that? Yes, I agree. It's a horseshoe kidney. As you can see, that the isthmus where the two kidneys are meeting, and the anatomy of horseshoe kidney can be really complex in terms of vascular supplies. You can see all the different variants of the vascular supply, and even the vascular supply can be coming from the iliacs as well. Preoperative knowledge of the blood supply of the horseshoe kidney is essential for safe operative planning. But more importantly, also, is being cognizant of the complex draining system for host kidney. And care should be really applied not to ligate the contralateral ureter, which is going to be very close to the tumor in a horseshoe kidney, and that's obviously a significant complication. So care must be taken not to do an early division or ligation of the ureter, and follow the ureter to ensure that this is a ureter draining the tumor side. And so that will lead us to the discussion of nephron sparing surgery. When is nephron sparing surgery indicated? Obviously, any patient with bilateral Wilms tumor should receive nephron sparing surgery, or should be considered for nephron sparing surgery and if feasible. Similarly, patient with solitary kidney, patient with predisposition to bilateral Wilms tumor, since they are going to develop metacarionous tumor in the future, so preservation of their kidney parenchyma is important. Again, horseshoe kidney would definitely require nephron sparing resection. Wilms tumor in infants with Dennis-Drash and Fraser syndrome, obviously these are part of the predisposition syndrome. Plus, Dennis-Drash has a really high incidence of end-stage renal failure, and so preserving any nephron will be required in that context. I'm re-showing the imaging that I showed early on, which was that large right side renal tumor, Wilms tumor with close side, and a contralateral Wilms tumor on the other side, confirming the diagnosis of bilateral Wilms tumor, and then exploring the algorithm of chemotherapy when we're faced with the scenario of needing to apply nephron sparing surgery. Obviously, all patients who require nephron sparing surgery should receive neoadjuvant chemotherapy. Obviously, there is some exception that we can discuss later on. Initial treatment of bilateral Wilms tumor require pre-doc chemotherapy for 6 weeks and evaluate CT or MRI, and then see after that interval, is bilateral partial nephrectomy feasible? If nephron sparing is feasible bilaterally, then surgery is indicated. No need to expand the chemotherapy beyond that. But if partial nephrectomy was not feasible, then we should assess whether the reduction was more than 50% in both kidneys, or the reduction in tumor volume was less than 50%. If the reduction is less than 50%, this really alarms for either a high risk histology like anaplasia, and then basically puts a brake on ongoing for further chemotherapy. And the option will be either to biopsy to confirm that what pathology you're dealing with, or attempt a nephron sparing resection or a complete nephrectomy if nephron sparing resection is not feasible. When the reduction in volume is more than 50% in both kidney, but still the nephron sparing was not feasible, then we can continue the chemotherapy for another 6 months, for another 6 weeks, and then do surgery at week 12. But expanding chemotherapy beyond 12 weeks is not recommended. It's basically a maximum limit of how we can expand the chemotherapy, since expanding chemotherapy beyond that is associated with higher risk of anaplasia. And I'm showing the picture of the nephron sparing surgery, which is essentially the conduct of surgery depends on the anatomy of the tumor, the anatomy of the residual kidney, and it can be summarized into 2 types of resection where the tumor capsule is resected intact but without a significant rim of normal renal parenchyma, which is the term used for that is inoculation, or when partial nephrectomy is done with a rim of normal renal parenchyma. Case control study of a large series of nephron sparing surgery was recently published, comparing the complication in bilateral versus unilateral tumor, and as expected, since bilateral nephron sparing resection leaves really a long row surface of the kidney, of the normal kidney, then it's associated with higher intraoperative blood loss, and also since it's associated also with complex, collecting system dissection, collecting system reconstruction or repair, then the risk of prolonged urinary leak is also there with nephron sparing resection. And the other issue is positive margin is obviously higher when compared to unilateral nephrectomy. The umbrella protocol further and defined nicely, as I have just discussed, the types of surgical resection into to A, which is partial nephrectomy, as I mentioned earlier on, and B, the inoculation, where the capsule of the tumor is intact, resected intact. And then the margin is also clearly categorized in the umbrella protocol to intact to the capsule, which is, given the number 0, or there is a doubt on the margin, there is a breach, a tumor breach, and that's given the number 2. And again, going to, this is from a surgical assessment, intraoperative surgical assessment. Also, the pathological resection margin is safe rim of renal parenchyma, resection margin, except on the nephrocalcimatosis, where that is not required. Intact pseudocapsule along the resection margin, and then the other scenario where the pathologically in the histology, it was seen that the tumor capsule is breached. And it also, in that protocols, gives a place to document what is the percentage of the remaining renal parenchyma. So, discussing some controversial issues like nephron sparing surgery for non-syndromic, so those patients don't have predisposition to, metachronous Wilms tumor, and have unilateral Wilms tumor. So we just have to iterate some fact that the main cause of renal failure in children with Wilms tumor are disease progression and exposure to abdominal radiation. It is not the nephrectomy. Patients who require unilateral nephrectomy have a really extremely low risk of end-stage renal failure. But progression of the disease will put the patient in trouble. So then all efforts should be done to prevent recurrence. And if doing a nephron sparing resection in a unilateral Wilms tumor who doesn't have really high need for sparing his or her nephrons, since he has a contralateral normal kidney that is not high risk of developing Wilms tumor, then the justification for doing nephron sparing surgery in unilateral Wilms tumor becomes really limited. And in fact, a patient who fulfill the criteria for nephron sparing resection in unilateral, that's criteria pertaining to safe resection margin with adequate, normal parenchyma, only is 3 to 9% of patients. I would want to quote this case report where this patient underwent MIS nephron sparing resection for unilateral Wilms tumor, only to present with multiple tumor nodules on the peritoneum, omentum, and intestine after the which was found at the time of laboratory. This image are from a paper adopting the COG. Obviously, if we talk about limitation of nephron sparing resection in unilateral Wilms tumor, if we want to compare COG to SIOP, obviously COG protocol will be even more limited for nephron sparing resection in unilateral Wilms tumor, since in unilateral neoadjuvant chemotherapy is not used, so the tumor size is not changed. And this paper utilized nephron sparing, sorry, this is actually, I apologize. This paper actually was utilizing minimally invasive surgery, not nephron sparing surgery, for unilateral Wilms tumor in the COG context. So the criteria was obviously the tumor has to be really small, not crossing the lateral border of the vertebral column, and then essentially that scenario is really limited in the COG context. We see on the tumor, we see a really large tumor crossing the midline, and there was no utility for nephron for minimally invasive resection. On the other hand, this paper is obviously from the COG area where the neoadjuvant chemotherapy is used. You can see that how large the tumor is in this picture, and how small it becomes after utilizing the neoadjuvant chemotherapy, making nephron minimally invasive resection, laparoscopic laparoscopic nephrectomy more feasible. However, when we examine the published result for people who adopted minimally invasive surgery for Wilms tumor, we found that this is really limited for tumors that are small in size. And in the COG, in the SIOP, 20% of those patients were found to be minimally invasive was feasible in Wilms tumor. And this is basically a picture showing the port side for laparoscopic nephrectomy. And but it was found that laparoscopic or minimally invasive, any type, whether laparoscopic or robotic, is associated with higher risk of inadequate lymph node sampling. And this paper tried to mitigate that problem by adopting a surgical approach where the lymph node sampling is done upfront at the beginning of the surgery before doing the nephrectomy. As you can see, the ureter is retracted in the vessels, and then basically the lymph node started to be sampled prior to contemplating doing the nephrectomy. This APSA systematic review tried to answer the same question we've been discussing about: shall we use minimally invasive surgery for Wilms tumor or no? And essentially, the finding is exactly what we saw in the previous paper, that this is limited to really small tumors. You know, like small tumor means 5 centimeter tumors, and it has been found to have some sort of a risk of tumor rupture that was seen in some papers. And so it's although it's not statistically significant, but it's a risk there. And the most important, when we look at the priority of looking after a child with Wilms tumor, I think that the overarching priority is to get complete resection with no tumor spillage. If minimally invasive approach would put the patient at any risk of tumor spillage or inadequate lymph node sampling, then this approach is not oncologically sound for that purpose. But obviously, I cannot make that generalization. Some tumors after chemotherapy may be eligible, and where the minimally invasive approach can be adopted safely. So back again to the discussion. What can you see? Yes, I agree. You can see some normal kidney parenchyma squished in the middle, and some changes all over the periphery, and no close sign, signifying the diagnosis of diffuse hyperplastic parahiral nephroplastomatosis. And that's basically all what is needed for the diagnosis. No biopsy is required, as we discussed early on. We got the diagnosis. How are we going to treat this patient? What is the next appropriate step? The bilateral nephrectomy, neoadjuvant chemotherapy, expectant observation, bilateral renal biopsy? You can answer in the chat. Yes, the answer is neoadjuvant chemotherapy. Histologically, they look like Wilms tumor. They just lack the pseudocapsule, and they are very prevalent in patients with Wilms tumor, especially patients with bilateral Wilms tumor. And diffuse hyperplastic paraorbital nephroplastomatosis should be treated with chemotherapy to reduce the risk of developing Wilms tumor. However, still up to a third of those patients may still develop Wilms tumor. And so the first patient, the image I show you, that patient received the new adjuvant chemotherapy as you recommended, and things shrunk down to those tiny, small things, and it was all good. And then 4 months later, in regrowth of multiple large nodules, they start getting bigger. What do you think we should do? What do you think the problem is? Do a biopsy, resect, or give chemotherapy? The answer is to resect. I agree, because first, as we mentioned, they are high risk of developing Wilms tumor. Not only that, within the Wilms tumor that they develop, they are really high risk of developing anaplastic Wilms tumor, as more than a third of them has developed anaplastic, in this case series, which doesn't really respond much to chemotherapy. And then therefore, in this scenario, going back and doing nephron sparing resection is one. Talking about complication for surgical complications, they are rare. Generally, they are 12%. Most common are intestinal obstruction, either secondary to adhesions or intussusception, which can happen with any significant large retroperitoneal operation. And it should be suspected when you have a postoperative patient who did really well postoperatively, but then started developing bilious aspirate, signifying interception. The factors that are associated with high intraoperative complication are intravascular tumor extension and all inadequate access to the nephrectomy, like utilizing flank or paramedian incision, or tumor that is larger than 15 centimeters. I just want to conclude with a couple of slides that the incidence of end-stage renal failure is really low in the unilateral Wilms tumor, higher obviously in syndromic patients. Again, in the 15% of patients with favorable histology, Wilms tumor develop recurrence. 50% of those who experience disease recurrence will go on to die from the disease. 50% of patients with anaplastic histology develop recurrence with poor prognosis. Regular follow-up every 3 to 4 months for the first 2 years is essential, as most recurrence occur within that time frame. Just want to also just highlight that the utilization, the need for doxorubicin and radiation therapy increase the risk of mortality. And then if we can avoid using the doxorubicin and radiation therapy, it will be good. How can we avoid that? The message to take home is if tumor is removed without upstaging, potentially we can avoid radiation therapy and doxorubicin, decrease long-term morbidity and mortality. And inadequate incision for resection or removal Wilms tumor increases the risk of tumor spillage and local recurrence, and the outcome of recurrent tumor is obviously poor. Failing to biopsy lymph node may result in inaccurate staging of Wilms tumor and high recurrence. Adequate staging is requirement for safe therapy and de-escalations. Urgent resection is recommended for tumors that are not responsive to chemotherapy. And for bilateral Wilms tumor, 6 to maximum of 12 weeks of neoadjuvant chemotherapy is recommended. It is critical that diffuse hyperplastic perilobar nephroplastomatosis be diagnosed, distinguished from a Wilms tumor, to avoid unnecessary radical nephrectomy in patient who is predisposed to develop additional tumors. I am happy to answer your question. This was the question we posed at the beginning, and I'm just going to answer it here. The only incorrect statement here is intravascular extension is associated with poor oncologic outcome. That's not true. It is still associated with good oncologic outcome, however, high intraoperative complication rate that can be avoided. I'm happy to answer your question.
Okay, thank you very much, Dr. Abdelhafeez, for an interesting and complex topics. I'll start with 2 questions myself. I'll ask a question for the sake of our juniors. Dr. Abdelhafeez, what is your preferred method of biopsy if you decided that this patient needs neoadjuvant chemotherapy and you want to diagnose before you give the chemotherapy? Do you go for CT-guided biopsies, intervention radiology biopsies, or like laparoscopic biopsies or open biopsies?
This is an excellent question. Thank you for asking this question. I will answer this question in 2 stages. The first question I want to answer myself, ask myself, does the patient need biopsy or not? And if the patient has typical age, typical imaging feature, then the patient does not require biopsy. You can start safely neoadjuvant chemotherapy. The chance of you giving the neoadjuvant chemotherapy that is not appropriate is extremely low. So it is now the consensus in different parts of the world, whether you're in the SIAP or the COG, or maybe the COG will still mandate biopsy for atypical pictures. But it's really safe to start chemotherapy without biopsy. Patient 2 to 4 years of age has close sign. What else could that be? Patient has bilateral disease in a typical age. What else can that be? That's just Wilms tumor. Start the chemo without biopsy. When you are faced with atypical pictures, that is age or imaging picture, then the question that you need to ask yourself, is upfront resection feasible? If upfront resection feasible, why would I even need a biopsy? I'll just go ahead and take the tumor. If upfront resection is not feasible, it's risky, and you have atypical pictures, then this is when you would need the biopsy. Other scenario, we need the biopsy when it is typical and everything, and you started chemotherapy without the biopsy, but the tumor is not responding. Again, you have to answer your question, the same question. Can I do upfront resection? Can I just go ahead and resect it without a biopsy? And if that's not feasible, then we'd discourage using open biopsy. The first choice would be an image-guided core biopsy, since the spillage resulting from that is limited. If you do a laparoscopic or you do an open biopsy, the expected spillage that comes with that approach is higher and is potentially disseminate to the entire peritoneum. While when you come with an image guide, the spillage is minimal and it's contained to the biopsy tract, contained to the retroperitoneal. That would be the first choice. I hope that answers your questions.
Super. And regarding if we're going like an off-age child or like non-typical presentation, either age-wise, radiological-wise, what preferred method do you like? Is like true cut biopsy is enough, or you would like to go for a surgical biopsy?
Great question. So excellent question, because I would still go for a true image-guided true cut biopsy with the caveat. If what you're dealing with is nephroplastomatosis, the biopsy is not going to help you, because the only thing that differentiates between nephroplastomatosis and Wilms tumor is the capsule. The biopsy, regardless of how you do the biopsy, it's not going to really differentiate that. If what you're dealing with is anaplasia, again, the biopsy may not help you, because anaplasia is not everywhere. Maybe the site where you land the biopsy, maybe the site where it's not anaplastic, where there's no anaplastic area. Even diffuse anaplasia, it's not in every single centimeter of the tumor. So, but yes, it will help with some other unfavorable histologies, like the rhabdoid, the clear cell sarcoma, and renal cell carcinoma and all that. However, most of the time in the scenario of renal cell carcinoma, it is the approach will be also upfront resection. It will be typical imaging picture. So why even bother and do the biopsy? Just go ahead and do the upfront resection. So generally speaking, there is limited place for biopsy in renal tumors, and when within that limited area, first choice will be CT or ultrasound guided or biopsy.
Super, excellent. Okay, I have one more last question. I know I have a very sad story for one of my patients. Actually, he was an off-age, non-typical presentation, incidental finding of a renal tumor that goes with Wilms tumor. He was like 9 years old with a left-sided tumor, with intravascular thrombosis reaching to the level of the diaphragm, like we're speaking about stage 3 intravascular extension. We took a biopsy and it turns to be a Wilms tumor, and he was about to start his new adjuvant chemotherapy. Unfortunately, he collapsed like prior to his new adjuvant treatment due to massive PE or tumor like thrombus. We couldn't catch him. How can we avoid this in the future?
That's a really excellent, complex question. And, it's really hard to prevent this, but there is criterion on this image that tells you the thrombus is at high risk of embolizing. And these criteria, most of the time, we're seeing in thrombus that are intraatrial, where they have like a sort of a narrow stalk holding the thrombus, the intraatrial component of the thrombus. Features like that really signify the risk of this thrombus is about to detach. And then if the thrombus looks as if it is about to detach, then this is also really a complex management scenarios. How are you going to then approach this, put the patient on bypass? How are you going to then prevent and protect the pulmonary vein from getting this thrombus? Obviously, there's a lot of technical issues and difficulties, but generally speaking, what you did is the right thing. You should have started the neoadjuvant chemotherapy. Neoadjuvant chemotherapy can avoid bypass in up to 80% or 70% maybe of patients who has extension in the atrium, and you give them or supradiaphragmatic extension. Up to that percentage, they can shrink down and avoid bypass. So, what you went through is really the exceptional scenario, and in this exceptional scenario, an early multidisciplinary discussion among the radiologists, cardiothoracic surgeon, oncologist, and the oncology surgeon would help inform the strategy. But I still would say the thrombus you saw was within the IVC. What you did is the right thing, but this is unfortunate.
Okay, because it was one of the worst nightmare ever, and then I was rethinking what should we do like in retrospect to prevent this in the future, because the thrombus actually it was in the IVC and it wasn't like above the diaphragm, it wasn't reaching the heart even, and it looks like a stable thrombus in the CT, no narrow stack, nothing. But I think the patient was unfortunate, or I'm not sure.
And somebody in the chat suggested a very smart suggestion of putting an IVC filter. This is not done frequently, but due to the difficulty of landing the filter above the thrombus and below the heart, because you have a really very limited zone. You want to put that filter without blocking the hepatic veins and without having a component of the filter getting into the heart. It's really difficult, but it's a very good thought. It may have some application in some specific thrombus anatomy, but generally it's not always feasible. Or actually, it's most of the time this is not feasible. But there is some, intraoperative maneuvers to have a sling around the pulmonary vein at the time of bypass, obviously, to protect, the pulmonary vasculature from receiving the thrombus before doing the atrial, opening and retrieval of the thrombus. There's some maneuver that the CT surgeon can do to mitigate the travel of the thrombus. But I think what you did is exactly what I would have done. If I've seen a thrombus in the IBC, I would give neoadjuvant chemotherapy.
Thank you very, very, very much for an interesting lecture. Really, it was a pleasure meeting you again. And we'll see you one more time again tomorrow, I think, for the neuroblastoma.